Okay. Today is talking about what? History taking.
Yes.
Your first week ya?
First week.
First week. History taking. So first of all, you know what clinical skill? Clinical skill is you have learned your first year, second year is the baseline skill. Clinical skill is application skills, a bit different from the basic skill. Now you are going to have to be trained clinically. Means that you have learned the knowledge or the basic knowledge, physiology, anatomy, pharmacology, pathology, biochemistry, microbiology. But now you're going to apply the knowledge. As we consider the basic knowledge into macam akar, root, so that we can build foundation on that on clinical skill. The clinical skill is involve history, physical examination, diagnosis, investigation, and management. These are clinical skills. So your another 3 years is how to your brain tu macam mana kita nak re-synapse as a clinician, as a doctor, in taking, so learn to take history, to do the physical examination, to make the diagnosis, to plan for investigation, and how to manage your patient. So for year 3, the key is the main thing you are going to do is taking and present history. Then after that, you will learn how to do the physical examination and making diagnosis and plan for investigation. That is the main thing. And management will be more, we're going to focus on the final year. That one only the basic management, because you will learn how to do a proper management when you doing your housemanship. Then after that, you finish your housemanship, you consider you have completed your clinical learning, in which by right you able to function independently in a safe manner. All right. Because the aim is that when you finish your housemanship, you become medical officer, which are you going to be registered as medical officer, you are competent. So the year 3 is only one step only in your clinical learning. So you know the preclinical with basic knowledge, anatomy, physiology, biochemistry, pathology, microbiology, and pharmacy. You have to be, you think that you learn too much, then you think that perhaps too much to be learned that you not use it. But actually what you learn during your preclinical is the basic knowledge of clinical, because you cannot learn clinical without preclinical. At a certain level, you need your preclinical to help you, to guide you in clinical decision. Very important. Don't underestimate the preclinical. Many good clinicians, they become good clinician because they have good knowledge in the basic, the preclinical. You cannot become a good clinician if you don't have good knowledge in the preclinical, basic knowledge. So clinical is applications, and it's all about how your patient, how are you going to now handle your patients, because your patient is define you, who you are, what the doctors all about. Doctors is nothing, it's about patients. That's why people will ask, whatever it is, like us, we are answerable to our patients, not to you all. We pass, we fail you whatsoever because patients, not you all. You're not answerable to you all. is about to patients. And patients is everybody. I will become patient one day. You also will become patient one day. And for whatever reason, nobody will not become patient in their life. One day they will become patient, including us. So what is the history? What is the thing that we want you to have to understand when we're talking about taking history? First is that you have to have a skill to extract history. Don't think it is something you get for granted. No, it's something that you have to learn. Some people, they know how to become busybody. Some people don't know. There's not much you can do about that. But it's a learned behavior. Learn behavior and skills to be able to extract history. It's a learned behavior. So the ability to extract history is something you have to learn. Sometimes, well, it takes time. We admit it. Like you take 10 minutes to get something about the history, whereas I will get down 30 seconds or 1 minute. This is because of the experience. But a certain time, we have to make sure that you know how to take history properly and adequately. That's why sometimes you found out why you pass and fail the exam, but because that we think that you are unable to extract the proper history. Even sometimes you cannot differentiate the history for the layman and history as a doctors. Sama saja kadang we found out. Oh, bezanya if you cakap layman dengan doktor punya history sama, jadi you unable to go beyond the layman. The second thing you have to have is ability to critically evaluate the history. Taking history is one thing, but you must be able also to critically evaluate the history. Very important. No point you had history, but you don't know how to evaluate it. It is also training. You have to train your mind on that. Many of you, by our culture, you have narrative brain. You listen and you narrate only. That's one thing. 90% of you are like that. Not much we can do because our education system are like that. Parroting only. That's all. But when you going to become clinician, you must be able to critically evaluate the history. And the last thing here is you must be able to present and communicate. You see, you may know everything under the sky. You may know everything, but people can only assess you, think you, how much you know, depend on how much the things that come out of your mouth. That's all. More things come out to your mouth, it means that it means that you have good because if you can open up your brain, look inside your brain to see, oh, you have adequate knowledge, then it's easy, but you can't do that. So most of the time is what the thing come out to your mouth. If you come out from your mouth ABC, we think you only know ABC. If come out from your mouth ABC until Z, we think you know ABC until Z. So, but we also have to understand what you know. And we can understand what you know if you can make us understood what you know. That is communication skill. So not much we can do. If you talk 10 things, but I still think you know only one thing, then not much I can think. I can say because I only understand what you want to tell, how you communicate. So we call communication skill. Something lacking with many of you, especially the Malay, because they're not able to communicate properly. And then you have to learn. But this all thing can be learned. How you get all this thing, you have to practice. No magic bullet. it didn't come from the sky, enter to your brain just like that. You have to practice it. Practice, and become part of you. So when taking history, so you sometimes you have to in children. One thing about children is that most of the time they are unable to tell themselves what's their problem, because of their insight, because of their vocabulary. They know things but they cannot explain it, and they cannot rate it how bad is it. So you have no choice sometimes, many times, most of the time, you to take history from the somebody who are close with the, or intimate with the children to know what's the child problem. If you big children, 14, 15, 16, perhaps they can tell you what's the problem. But in my experience, less than 12 years old, many times you need parents to tell you the problems. And whom you take this history? For the mother, caregiver, patient, father, and sibling. I give this a rating, so you understand the main thing is the mother, caregiver, patient. Sometimes patient can give the history. Father, you have to be careful, but there are those father who can give good history, but there's some father who are be too proud. Too proud. You ask things, they because they are unable to give this history, they make up the history because they are too proud for themselves to tell they don't know. To be careful. Siblings, their perception is different. So you can ask the history, but you have to be careful the sibling perception, because many of them still children. And then the principle of the brain, the principle of history is that there are this called W things or inside your mind. Anything, any symptoms, any symptoms, any event you have inside your mind, when, why, where, what, who, which, how. If you have this in your brain, your life become easy. That's all. If you don't have this in your brain, you're going to suffer. That's all. You have to have this inside your brain. And then your brain also must work in chronological order. I mean that many times you cannot format your brain properly, understand the case, because you enter in term of temporal time tu, sekejap depan, sekejap belakang, sekejap past, sekejap present, so it can problem. Your mind must be organized such a way in terms of chronology. 5 days ago, 4 days ago, 2 days ago, 1 year ago, 3 months ago, 1 month ago, and yesterday. Your mind had to organize like that, right? And then it has to be clear and logical. If you're not clear and logical, you ask the story, the history again, until the history become clear and logical. So it started with chief complaint of chief complaints, because nobody come to see a doctor without complaint. Is if somebody come to see you saja, something is not right with the person, is it? Or they want something from you. Because if anybody come to see a doctor, they have reason, they have something they want to complain, to tell you what's their problem. And you see, your thought foundation in managing this case is the chief complaint. If you are unable to decide the chief complaint of the patient, something is not right about the case or about you. Something is not right. You're unable to decide what is the chief complaint. Something is not right. Chief complaint, usually one complaint, but sometimes it can be many complaints. Doesn't matter. But that's the thing brought to see you. Remember, to see you mean that to go to ED, to see you in the GP, see you in the PKD, pusat kesihatan, doesn't matter. The chief complaint can be different. Let's say they see you, they went to PKD, see you because of fever. 2 days later, he becomes shortness of breath, so he come to see ENE, immediate because of that. So chief complaint is when if your point of seeing the patient at ED, so the chief complaint will be shortness of breath, because he came to see the patient you because of the shortness of breath. But at the point if the point they see you at the PKD or clinics, fever, the chief complaint will be fever, though it's a same patient, because that's the reason why he came to see you. So why the reason why the parent bring the child to see the hospital? Same, and chief complaint used most of the time is a symptom or symptoms, a set of symptom or symptoms. Sekejap, sekejap, you tunggu sekejap. Sambung ada juga. Ini kan Awi dia nak pergi ke nak fulfill dia punya NSR punya logbook. So we decided easier for him to go to USM lah. So the plan is 1 month just to fulfill dia punya logbook dia. And then we gave him daripada bulan 1, bulan 3 sampai bulan 3 1 month, plus intubation, everything semua 1 month. So he will do you in ICU 1 month, stop for a while. Then this 1 month is tak sure lagi. I'm thinking of 2 weeks attachment ke HTAA, IPICU. Attachment only you need to just observe what people are doing there. Because attachment tak payah nak minta permission sangat. Isn't that patient to observe. And then 1 month finish with you lah.
So dia bukan start Februari lah.
Sebab dia tak nak pergi bulan puasa. Sebab anak dia tahu dia tak ada orang gaji, anak 5 orang. So dia nak pergi kalau boleh bulan puasa start dia.
Asalnya dia patut start nikah Februari kan?
Februari. So 1 month dengan you nanti.
So Februari dia dah start ke belum?
Dia start.
Februari dia dekat nikah lah?
Nikah lah.
Okay.
After that 1 month will be here. Dekat USM. Kalau dia confident USM mudah lagi nak dapat. Kalau dia familiar kat situ. So yang nak suruh USM nak cari orang pujuk siapa kan.
Surat ke sana?
Surat nanti suruh Taufik buat, nanti suruh tunggu Taufik. Dia akan buat surat, Taufik sign.
Kau nak balik?
Surat 3 ni 1 month. So I'm hoping bulan 5 tu dia habis semua lah. Terus dia treat a specialist here. Walaupun dia bulan 7, bulan 8 dia sini hospital tu, you akan gazetkan dia. Dia start sini. Itu satu. Is the one lah yang tunjuk ke you. Okay, I discuss Sophie dah tahu. Sophie, kita akan cancel this one. This one kita cancelkan.
Semua?
Semua. Sebab Sophie pun kata, why we must have asset maintenance? The government give us 50 million, 60 million per year to maintain. Dia pun tak tahu this one. So we going to use this one only. Petang ni sepatutnya datang siapa tu? Sahih. Betul lah. Dina pun datang to sort out. Fadzil nak cancel this one. Because yang ini yang killer ni. So even ini kena ubah. Sebab you see dia charge satu tank 1,008, tapi sekarang pasien pakai cuma 1,5 saja atau 1,3 satu. So you need a formula. This one tau, artinya kalau 3 liter ni, 3 liter you pakai 3 liter kan. Satu tank tu berapa patient boleh pakai? You all. Roughly.
Satu dia depend on berapa lama.
Roughly. 1/3 unit, ada tak 1/3 ke atau 1/5 unit?
3 patient kot yang last time tu.
Tapi you punya 3 liter ke 2 liter boleh tak check dengan ni? 3 liter. So dalam PSU besar ni 3 liter, rasa you 2 liter je. 2 liter rasa dah cheaper. Harga lain.
Tak pasal nak buat 2 liter.
You punya 2 liter rasanya, 3 liter 2 liter. 2 liter rasanya. Kalau harga mungkin less. So ada tak 1/3 atau 1 unit dia 1/2, 1/4 unit. 4 unit less lah. Di dalam 400 atau 500 ni boleh jadi ni. Ni yang gila ni. Banyak benda lah yang ni. Lepas tu costing yang ini. Tapi costing dia, beritahu you, ini bisa ubah. Bisa nak sudah because dia tu jadi tukar equipment lah. Kalau tahu kenapa nak tak anestesiologi, tak equipment saja. Tapi
Sebab coding ni is NS punya coding. Kita guna NS punya coding. Sebab tu,
tapi dia dah lama dah ubah, sekarang tak ubah. Macam mana nak ubah? So patut menjadi equipment dia senang. Tak coding macam ni. Oh dia dah ubah.
Ibu macam ni lah. Dia pakai NS punya number. Ini semua NS punya coding. Ni pun ni kan. Ini
Because you see
dia charge untuk 11 hari dia charge.
Tapi 1,900 tak banyak sangat. 1,600 tak sama tau. Ada 1,600, ada yang 1,300 satu hari. Ini dah 160 satu hari.
Nah, itu yang saya tak faham sebab sometimes yang ini kan dia tak nampak kod berapa tau. Itu saya dah tengok itu. Yang number coding sama tapi charge dia berbeza tau. Untuk feeding, untuk apa. Saya pun tak faham apa dia punya ni.
Itu yang boleh ubah saja jenis site yang ni tau. Background itu ini yang ni the same procedure tak ubah. Ini tak boleh charge. Tapi tak tahu macam mana. You betul dah nurse semua prosedur yang nurse buat. Ini jangan charge. Ini semua lain you boleh charge.
Charge under gynae punya coding. Macam yang pelik tu.
Ini tak boleh charge.
Ini charge under ni apa? Kenapa kena charge under warna ni tu? Apa benda ni dua ni?
Ya, tak tahu kenapa ni.
Ni feeding dia charge under ni manual feeding and scholarly intervention. Satu ni RM12 tau. Satu ni RM12 satu. 74 kali feeding. Tengok 1,700 untuk bagi feeding.
Tapi kalau bagi feeding patut tak boleh charge.
Gila tak? 1,700 ni untuk bagi feeding. Ini tak tahu ni apa benda ni. Ni apa benda tak tahu ni. Ini tak tahu. Yang ni memang dia bagi feeding, tapi sebab kita tak ada option untuk bagi feeding tu, so diorang guna ENT punya coding. Coding ENT ni bukan PIC punya coding. Sebab tu dia keluar ni saya rasa ni adalah speech therapy punya dia buat sound intervention kan. Ni sebab tu RM12. Tapi dia tu tak charge 74 kali. 1,700 untuk bagi makan ni berapa hari ni.
Tapi kalau nurse yang beri makan, nurse yang dia tak boleh charge. Dia boleh charge susu saja.
Itulah dia. Tapi saya cakap ada orang lah, saya tak boleh charge lah.
Ini lain ni semua macam ni boleh charge. Ni boleh charge
Yang ni yang mahal. Ni lah kot. Blood gas satu.
Tapi satu blood gas dalam 800 dan 900.
8 kali. Itu mahal gila dia charge.
Siapa yang charge ni?
Ini lab lah. Walaupun kita buat kat kita punya ni.
Kita punya apa?
Kita buat kat kita punya gas lah.
So kita punya gas.
LFT kira 100. Buat kaca memang buat kaca 240. Satu.
Kalau apa harga ni harga lab. Ini kita boleh kita punya lab kita sendiri kan. Ini kita sendiri kenapa kita
Actually saya nak macam orang
ni semua.
Yang bilirubinometer tu lagi mengarut tu bila check tu.
So bila dia kata cancer bilirubinometer kat sini.
Apa yang ni kan? Betul. Saya kan. Gila. Kan? Kadang kita charge kan harga satu kotak tau. Ini surgical glove. Kira ni RM2. Itu saya nampak dia charge harga sekotak. Macam blue sheet kan. Semua dia charge harga satu roll.
Apa?
Blue sheet
apa?
Benda-benda yang diguna, benda-benda kita guna kan. Blue sheet ni. 18 RM16. Ini harga satu roll ni. Bukan yang satu keping.
Blue sheet apa?
Yang dia orang buat alas tu. Sebab tu lah, satu benda, saya nampak glove ke, dia charge harga satu kotak rather than rather than mana tu. Ini okey lah.
Bila tak boleh sedang apa benda yang orang charge ni. Aku dengan dia sekali lalu, sahih petang ni. Lepas tu nanti aku satu lagi, satu lalu lagi dengan dia. Saya nak finish, saya nak finish kan.
Ke sini dah banyak apa ni? Oh, ni baby also tadi yang ada outside tu.
Dato' set dia tak charge pun.
Ini on. Bukan ni.
Maybe dato' set tu di mana?
Kan kena PPSN tu lah. Tak selesai ni PPSN ni doang tiba-tiba. Dia government servant dia dapat diskaun 5,000.
Ada.
Kata saya ni PPSN ni betul tak ni.
Tapi tak ada kan? Dato' set tak ada kan? Tak charge. Apa dia dulu lah.
Ni sweet ni sweet.
Dato' set masuk je. Ada tak boleh masuk dato' set charge dalam tu? Ada sebab tak ada dato' set dalam tu.
Kalau dia tak tahu nak cak ni cuma lagi. Jadi dia tak jumpa. Dia belum boleh cak lagi. Belum boleh cak.
So you check this one, you tank berapa ya?
Ada 3%. Nah ni sekarang ni pun nak cak outside dah. Oxygen delivery ni saya tak tahu apa yang dia consider 15 ni. Dia charge per day ke apa?
Yelah. Boleh check ya. So, dia tak pakai lah bila check ni. Tak pakai lah.
Guna je.
Tapi tak charge.
Tak salah saya suruh dia tak pakai dulu je.
So sekarang ni harga lain passion dah naik lah. So ada charge lengkap,
Itu dah je. Tengok ni susu. Ini saya discuss dengan dietitian. Saya pernah cakap dengan orang lah. Dia kata memang kita kena sit down dengan orang untuk bincang. Kita cakap sikit. So RTF ni satu botol dah yang ready to feed milk susu. Okey lah 16. Maksudnya sebab memang kita bagi satu botol tu tak share. Tapi ni 400 gram ni harga satu botol ni, satu tin ni. Wah, nanti nah, 180. 2 tin kita charge kat dia.
Itu akan habis.
Oh, memang tak pakai habis sebenarnya. Jadi non prohibited ni kita charge 2 tin dengan harga ni.
Tapi pakai tak?
Dia pakai tapi tak boleh, lepas tu kita tak bagi kat patient. BCG pun sama. BCG pun kita share patient.
Tak tahu, ibu tahu lah. Okay, kita go through nanti. Tapi bila meeting tu, nanti kalau you tak meeting topik konflik lah nanti kan. I tak apa, dia tak berani apa. Okay ha. Okay, history most of the time is symptom or symptoms Symptom ni tahu apa tu tak symptom dan sign tu apa beza?
Symptom tu patient rasa.
Symptoms is what the patient rasa or what the parent parent observe right? Parent observe no. Kadang-kadang parent dia cerita pada you dia nampak budak tu dry lip or sunken eyes the mother notice sign is what when you do the examination. So sign is when you do the examination you found something that is the sign. The symptoms is what the patient feel, but in children it's not practical. What the mother complain of and the mother notice. Let's say the mother notice sunken eyes. We will be inside the history. If you examine, there is a sunken eyes, it will be in the physical examination. So some signs can still be in the history because of the what the mother noticed. Because you don't expect 3 years old child going to tell you that the drip is live, the drip is dry. Even 2 years old to tell you that thirsty pun dia tak boleh nak beritahu. So it depend on the mothers, what the mother tell you. Okay. So history after chief complaint will be history of presenting illness or present illness. So the history of the present illness, HOPI illness. It doesn't say diagnosis. It doesn't say anything. It's just illness. The illness can be acute or can be chronic. Let's say the chief complaint is related to a hypertension. So it's a chronic disease which you have to start the illness from when this patient have a hypertension or patient got acute exacerbation of bronchial asthma, then the illness is start when the patient having start asthma because it's presenting illness. If you're talking about acute case, let's say bronchopneumonia, nothing else. So you know that the history will be the shortness of breath because of the bronchopneumonia is an acute case. So it's going to be the 3, 4, 5 days history only because the illness is the bronchopneumonia. So you want to realize the history of presenting illness. So it also has to be contained when it happened, where is it, why, what is it, how is it. It's always there. It have to be there. Any symptoms, when the fever start, why it having fever, what they're doing every fever, what the fever is all about. So where patient are falling down, where is it? Or fitting, where is it? When the fit start, where is it berlaku? Why patient have been fitting? What the fitting all about? Fitting, what I mean that is the character of the how is it? To remind you back, chief complaint, you don't need to characterize the illness. Fever for 5 days, finish. Fit for 4 days, because that's the mother going to complain to you. Chief complaint 1, chief complaint 2. Fever associated with fit, more difficult. So fever 4 days, fit for 3 days, finish. Chief complaint, that's what the mother complain. So history is with the chronology. Chronology is that every symptom 4 days ago there's a fever, 5 days ago, first day fever is not very high. On the second day of fever start to be high and intermittent. On the 5th day, fever very high and persistent, the child start has chills and rigors. So chronological order, you don't start, the 2 days ago fever is high, but 3 days ago fever is mild fever. You don't present like that. You present chronological. And you have to decide it's acute or chronic, as we discussed earlier, case, because acute, how you present history will be a bit different from chronic. Because acute is about more of the condition, the current condition, but chronicity is the story of the illness to the patient. And then any history, you must able, when we listen and when you present, you must be able to tell us how severe is it, mild, moderate, or severe. So asthmatic attack, is it mild asthmatic attack? The child only got tachypnea. The second child got tachypnea and chest recession. The third child is having tachypnea, chest recession, and cyanosis. So we know already the last one is more severe. It's all inside the history. And history have positive history, negative history. The child is having shortness of breath. There's some chest recession but no cyanosis. The child is got shortness of breath with you have tachypnea with chest recession and cyanosis. You see, cyanosis can be positive and negative history. When it's positive history, it tells us how severe is that. If negative history, no cyanosis, it tells us it's less severe. So positive history and negative history are equal important. Keep in mind that it's equal important, because it tells us the severity and it can exclude the other causes. Now, systemic review. They got two types of systemic review. One, though we go system. One is systemic review related to the chief complaint. When you go, you ask the question because you're not experienced. You want to make sure you don't miss anything. So anything chief systemic review that related to the chief complaint will enter into HOPI, will be part of HOPI. But sometimes you ask the systemic review because you don't want to miss anything. Let's say the patient got shortness of breath, at the same time probably got some small cellulitis at the leg. Probably not related of the chief complaint, but at the same time the patient did have that. So that one can become a positive history, but will be a systemic review about the skin, but not part of the chief complaint. So it will be a stand on its own. So you have to realize, right? Systemic review. So you don't go systemic review ni semua nak masuk become a stand on its own. You dah present the shortness of breath, patient got rapid breathing dalam HOPI, suddenly the systemic review you kata, respiratory got rapid breathing. You repeat what you have present HOPI. And furthermore, that systemic review is part of the HOPI. It make people listen very confused, and then you make your history jangga-mangga. So when you finish all this, then you have to take the other history to complete your history taking. So you have the history HOPI, and then you go the other history, past medical history. Past medical history is any history, other history that patient has not related to the HOPI. You mean that, let's say patient got asthma. Few years ago, he was operated for appendicitis. So the appendicitis will become past medical history. Let's say patient acute exacerbation bronchial asthma, but he was having admitted this day. 6 months ago, he was admitted also because acute exacerbation bronchial asthma. So that one would be HOPI because it is still about the asthma illness. It's not the history or the past medical history because it's still the illness of asthma. And then birth history, including the antenatal history, you have to take any patient, any children, because it's part of the history. Sometimes probably it's relevant to chief complaint or not, it doesn't matter, but we want to know the patient as a whole. Feeding history, dietary history has to be completed. We have to know as a whole. As patient as we have on the whole picture, maybe important in the chief complaint, maybe it's not important, doesn't matter. Immunization history also we want to know as a whole. Because let's say your patient got strep pneumonia, pneumococcus pneumonia. Immunization history will be very important. It can be even part of the HOPI because patient is not taken pneumococcus vaccine. Very important, that one. Even you don't need to wait until immunization history. You can put inside the HOPI already to tell us that why the child is having pneumococcus pneumonia. But what about the measles and the rest of the thing? Still, you have to put inside we have to know the history of immunization for the measles and the rest because we want to see the child patient as a whole. Developmental history. The developmental history is part and parcel of pediatric history. It's something you don't have in adult. So you must know the parameter a milestone, roughly, when the child is like gross motor, I mean the progress of, they got two things, yeah. When you talk about developmental history, first, how the milestone. Second, what the patient can do now when you saw your patient. Got two things. Keep in mind of that. So basically, we put it as gross motor, fine motor and vision, language and speech and social. That's four things. Yeah? So milestone, you don't need to know everything. You just remember the important milestone. Like one patient able to roll over, one patient able to sit, one able to stand, one patient able to walk, run, and fine motor, one patient to able to hold both hand, one patient to reach object with two, one patient can reach object with one hand, one limb, and then one they can transfer object, and then one they use the pincer grip. That's all you need to know. But that one is to see the milestone. But at the same time, we may also ask you what the patient can do now. He can walk, he finish now. He can write a few sentences, or he can use the pencil grip. Okay. He can speak one words. He can speak two words, three words. He can make simple sentences. Okay. Social, he able to socialize. He got a stranger anxiety, no stranger anxiety. He can socialize with the sibling. He can socialize with the friends. All these things. And then second thing is cognitive. It's roughly how the patient is. Let's say his mother can tell you that a child is 10 years old but still in standard 1, or still unable to, very bad in the class, or very delay in special school, because it tell you the cognitive. Family history, you have to construct the family history, parent. Okay, for certain cases, CNA patient got fitting patient, seizure. We may want to know a patient with cerebral palsy, patient with delayed developmental, and then developmental history have to be detailed, because that is the key history about the patient. If patient got bronchopneumonia, probably the developmental history is more of the screening. Screening to look if patient have delayed developmental or not. And then at the end, the mother can tell you the child is develop as fast as the other sibling. They tell you already the child is normal. But but still you have to know the milestone, and also you have to know the current patient what can do. But if the child got fit at the age of 3 years and the child got neurocutaneous sign, then we have to know the detailed history, because we want to know what the patient delay. So if patient 4 years old, at that stage, when you came to see you, but developmental, we can decide only 2 years old. We know that the patient got 2 years delay. It helps us a lot in managing this kind of patient. Family history, construct family history. At least parent should, if the patient don't have genetic disorder or those things, at least you can construct between the first layer, the parents and the sibling. But if the case is genetic case, involve autoimmune recessive, autoimmune dominant, or those things, you need to three generation. You construct 3 generation. 3 generation construct family tree. But if the child doesn't have any, the case came to you, the chief complaint not related with genetic disease, at least has to be 1 layer, the parents and the siblings. And you have to mention if consanguineous or not. And then if genetic disease, your construction of the family tree can tell you the pattern of inherited. Other history, drug history, or medication history, what have been used. What if the child is asthma? The child asthma, and the child is using fluticasone and fluticasone and salbutamol. You think where you're appropriate to mention about the medication, this medication, in the drug medication history or HOPI? Anybody? Anybody?
HOPI.
Yeah, HOPI. Yeah, because it's related to the illness. But if this child is asthma, but he's using a fusidic cream or he's using asthma, but he's using medication for hypertension, so hypertension or medication for nephrotic syndrome, then you put it inside the medication history or drug history because it's not related with the patient illness. Social history, daily activity, social school, we have to know. So you have to be clear because we want to see the patient as a whole. Because the patient, children, they got schools, they got friends, they got play activity, they got all those things, how the disease affect their school, like asthma, like nephrotic, how much they miss school. We need to know that. Patient with cancer disease, so how it affect patient with asthma, bad asthma, so how asthma affect the daily activity. We need to know all those things. Environmental also very important because certain disease involve environment, or sometimes we need the environmental history to see the patient as a whole, or sometimes environmental history also part of the puzzle of the illness. Like asthma, you know, is the stay in the house where a lot of factory pollution, it will be a very positive history. Even I will put inside the HOPI to tell everybody that the environment pollution contribute to the asthma of this child. So you have all this, you already you finish clerking the case, complete. So the next thing come to you is the critical thinking. So what the thing that you have, the thinking process that you should have. Okay, first of all, you have to have this background, anatomy, physiology, biochemistry, all the preclinical, your background. You already have this as a background. You don't have this, then bad of you, so bad. Not much we can do about it. It's something that you have achieved, you have passed the exam, preclinical, and then we expected you, when you pass the exam, the preclinical, your knowledge is there already. If you lost it, or because you hafal, you learn it because for exam, after the exam you forget about it, then that's too bad. Because you belajar nak exam, tak ada berkat, jadi you tak boleh ingat apa you belajar. Then not much we can do, you kena baca balik lah. Tapi kalau you belajar niat you lain, mungkin benda tu keep with you, and then it become a basis of your thought process. And then you have to ask, related with chief complaint, what's the problem? Where the problem? When is it? What is the process? Which process involved? Is it infection? Is it inflammation? Is it tumor? Is it endocrine? Which system involved? The main system. Maybe they got 2 or 3 systems, but we want to know which the main system involved. Any other system affected? Is it acute or chronic cases? How bad is it? Is it mild, moderate, or severe? And what is the complication? So all these things come to your mind. All the things come to your mind. When you see the patient, how to solve it. All the things come to your mind. And then after that, you already have your thought process, and then you already sit down, you're thinking about the case, then you want to present the case. You see, you are macam tukang masak tau. You got all the data ingredient. Your ingredient is the data. We ask the patient give you the answer. That's called data. Data, all the data. your data. So the thing is that where critical thinking is that how you want to present your data. You want to look at your data and make it logical and clear, and then now you want to present your data. You want to present the data, tengok dia tukang masak yang bagus, sedap lah dia. Makanan dia susun dia pun lawa, attracted. People dengar pun attracted. Oh, very attracted, very good. You lousy, wah, tak selera. Dengar pun tak tahu. Kita yang dengar pun jadi confused. Apa benda dah budak tu nak beritahu. Because we can only, because we're not going to clerk the patient. You clerk the patient. You present to us what you know. So the presentation is a skill that sadly you mesti ada. Part and parcel of clinical. And you're going to use it for the rest of your life. Because every time you're going to discuss the patient with any other people, present it, you have to use your communication skill. But communication skill is something to be learned. Don't worry. Some people, they are built already, they have the innate communication skill. Macam mana genetik ke apa ke, we don't know. Some people don't have it very well. But that doesn't matter because all this can be learned. Even if you, the person who are weak, they are persistent, they become better communicator than those who are gifted but didn't practice. Believe me. So the key is to practice. Presentation as usual, introduce your patients, the source of the history, then what the chief complains. As I said to you, don't characterize the symptom, the chief complaint, just tell us the symptom and duration. Then tell us the HOPI. HOPI is anything related to chief complaint. Even in systemic review, you noted that the thing related to chief complaint, it become chief complaint, it become HOPI. Go to when, why, what, chronological order. Always remember chronological order. Yang pergi balik 3 hari, pergi balik 5 hari, 2 hari before admission. Your point of entry is ground zero is admission. If you are at your stage lah, where patient come to see you, at moment for your training when the child admitted. After the admission, it's not anymore HOPI. It is a progress in the ward where there is intervention from the doctor already. Progress on the ward for your training is until admission. This is ground zero. So, I mean, what happened in ED also part of a HOPI. Unless you work in ED, then the ground zero is the ED. I mean that before you do anything at ED, is the HOPI. So that is very important when you present chronological. Always that. It's also a problem in my MO. Tak boleh present chronological. Look for the severity when you present of the problems and then the complication of the problem. If the child develop, let's say, hypertension, if the patient have any complication of hypertension or not, such as intracranial bleed, heart failure. So look for complication also. And then very important, keep in mind, positive history and negative history are equally important. Not only positive history. Many of you, positive history only 50% of the mark. Another 50% of the mark is negative history. So very important. Fever with rash, fever with no rash. It tells us something. Even if patient got rash, patient don't have rash and fever, it tells us something. It tells us fever with no rash. It tells us something. It excludes many things. So it's as important as positive history. So systematic review. So which is not related to HOPI, then you go for the past medical history and other history, and then if you've been asked, then you present progress in the ward. What is the progress in the ward? So no magic bullet, practice make it perfect. No magic bullet. Dia tak datang tu masuk dalam otak. No, it have to be learn and practice. The more the practice, the better you are. That's the rule. Okay, any question? Any questions? Tak ada. So you know everything already lah. When principle, if you know questions, there are two things. Either you know everything, or you know what?
Nothing.
Nothing. So I always positive mind. You are very intelligent people. So I assume you know everything. Okay. Fair or not fair? Eh? Fair, not fair. Eh? Eh?
Fair, fair.
Or you don't know what you don't know. You don't know what you don't know. Ah.
I have a question. Nowadays, many of the parents have some kind of books that shows the progression of their children, right? So is that can be considered as our KPI?
KPI. Can. That in real life you are going to use the book, is it? That's real life all about. Any other questions? No more questions.
Dato', is regarding our next lecture on respiratory examination.
Friday kan?
Friday.
Tunggulah. That's the time. Any changes I will tell you all.
Okay.
Jadi morning tu mesti ada meeting, COVID meeting. Tengoklah macam mana kalau sempat kita delay kan. Okay.
Okay. Boleh.
Pukul 11. Lecture tu 45 minutes. Pukul 11 boleh buat juga. Tengoklah. Okay. Kalau COVID meeting short, tak apalah. COVID meeting panjang, delay sikit lah. Okay, finish. Dia tengok kita orang masa tengah pergi lecture pun ada meeting juga kan, ada discussion. So our life are like that je. And everybody have to do something. Okay, okay. Tapi that's how you learn to become multi apa? Multi-function, because you can do other things and you can go back doing your things. Because your mind got multi-layer. Okay, finish.